Welcome to another episode here of Black Health Now with Dean and Doc. Diabetes. Is there some good news about diabetes? Do you trust the mandates that are being relaxed? Do you trust that your booster is keeping you safe? All these stories and more here today on Black Health Now with Doc and Dean. Good afternoon or good morning.
Good morning. Good morning.
Welcome you and thank you all for joining us here on another episode of Black Health Now with Dean and Doc. And what we're here to do is we give you the latest health news for Black Americans, the stuff that you can use, the things that you can share with your friends and make yourself look smarter each and every week. We're going to interpret it for you and give it to you in a very newsworthy format. Also, as we do at the beginning of each show, let us know where you're watching from. Put that in the comment section. We'd like to know where people are watching from. And we'd like to know those topics, those subjects, those things that you want to know that are important to you and your circles and with regards to health news. And so we're going to get that to you. We're going to bring you the latest and greatest here each week on blackdoctor.org in partnership with the African American Wellness Project. So, as you know, it's not just me by myself. It is Dr. Michael Lenore, the man of the day, the man of the hour, the man of the week, the man of the month, even though it's March and his birthday was in February. Hello to you, Dr. Lenore.
Yeah, how you doing? Good morning. Good morning. It's a little early out here, so in the West Coast, but a lot of things going on. One of the things that seems to be almost unimaginable that something would take over the discussion on the COVID situation, the pandemic here, because this war in Ukraine. I mean, this is some major stuff, and eventually this is going to affect every one of us, and especially if they start messing around with the nuclear stuff. But I want to present that first slide, Ellis, to show you that things are still not controlled, particularly well controlled in the COVID space. Last week, there were 5,400 cases, 1,500 deaths this week, with African Americans getting infected about the same rate, but dying twice as often. 80% of Americans gotten at least a dose, 60% 2 doses, but only 30% have gotten the booster. More than 4.9 billion people worldwide have received at least 1 dose. But one of the things is about the booster and these statistics. What makes me a little uncomfortable, and maybe you can comment on this, is that we're changing the mandates. I mean, we're changing recommendations about mandates and social distancing, and I think it's a little bit. It makes me a little bit uncomfortable.
It's a bit, many people have said it's a bit premature. Some people are saying that it is too late. And they're saying, well, why do we have these mandates if you're just going to relax them like this? And so there's more confusion surrounding the rules with regards to COVID, as there's been confusion since, the beginning of this, from February of 2020. There's been confusion. And so what I would say to anyone that asks me, and I'm not the super authority, but I would say this: do what you need to do to keep yourself and your family safe. So I would say start at home, and as I say my phrase, keep home safe. So whatever you feel is going to keep home safe, don't rely specifically so much on what the mandates are telling you to do. Do what you feel is best for you and your family to keep yourself safe.
In order to discuss, since I was so uncomfortable about this, I went to some local experts to talk about this whole issue of the changing mandates and whether we're doing it fast enough. And that third video, I think, chronicles that discussion, and the one after that.
And some of the communication, which has not been optimal, and all of that will just continue to kind of erode trust. I think most of us who are in this work have really tried to be humble, that we don't know everything, that things are changing and evolving, and that having that trusted relationship like what you have with your patients is so critical, because at no point, I'm sure, would you have said, oh, this is it. I absolutely know for sure you're going to be done after the second dose. We've had to admit that we just don't know. And we're learning as much as we can as we go. Being able to, I think, effectively communicate in the midst of uncertainty is something that we've seen be a major challenge throughout this pandemic. And I think it has really affected how individuals then take that information and act upon it. And I think, unfortunately, for our community, oftentimes it might just take a little bit longer to get the data that they need, have those conversations with the trusted people in their lives that are healthcare professionals. And we just don't want it to be too late. And when policies come around, like lifting up the mask mandates and so on, then we start to lose even more layers of protection. And that's when we start to get even more concerned.
You and your whole organization has been very effective in messaging. What principles do you use in trying to talk to elements of the community that you serve?
Well, I think a big part of it is we just didn't pop up when COVID popped up, right? We've had a long-standing relationship and have built trust in the community by really focusing on the needs of the community and responding to those needs through the work that we do. Hiring folks from the community, basically being a part and an anchor within the community. And so all of that sort of had us in a position where when the pandemic hit, people were coming to us asking us to help sort things out. And so we just built upon that from there and realized that it wasn't enough for us to just talk to our own patients. We really had to go more broadly with it. And so that's when we really started doing more community level, I think, COVID-19 education in particular, because so many people in the community were just confused. Information is coming from every which way. It felt contradictory oftentimes. And so we felt like it was really important, being who we are in the community, to just cut through that noise and give people information that they needed to make choices that would keep themselves and their families and their communities as safe as possible.
What would you suggest to other large systems? I mean, how do you evaluate their messaging, their involvement, their opportunities to gain the trust of the community? I just saw an article from the Windows guy. I'm blocking on the name now, but he said that this is not the last pandemic, and if we don't do something, we're not going to be able to be any more effective than we were this time. What do you suggest that large systems do now, so that if this happens again, when this happens again, that the public will be a little bit more responsive?
Well, unfortunately, it's not a short answer, because you are asking about how do institutions with legacies of really doing harm in our community, how do they overcome that? And that's something that they should have been working on long before COVID, and they will continue to need to work on long after. And so I think it starts with caring about that, caring about the fact that these are institutions that have historically done harm. They haven't done the work needed to build trust within the communities. They often continue to do harm every day just through bias, whether it be conscious or unconscious. And so it takes a lot of that looking inward to correct those things and to at least try to understand even disparities within their own systems. So if a large system finds out that there are wide racial disparities, it's not enough to just say, oh, well, that's just how it is. Healthcare has to take responsibility for that. That is our job. And I think we have to start seeing it as our job. And so I think that is actually the place to start.
You and I had a conversation not too long ago where you made the economic argument for being more inclusive and being a little bit more sensitive to the needs of the total community, by explaining that until we take care of the least of us, it's going to cost the rest of us a whole lot of money.
Absolutely. I do think a lot of it starts with providing opportunities within community, hiring from the community. Even within healthcare, there are so many barriers to entering within healthcare, and then we wonder how systemic inequities get maintained. I think it's really important that we think about how to include folks from the community who are from the community, because they have the best understanding of all of the barriers and how to do this communication in the first place. Oftentimes when you see communication coming out of some of our larger entities, it just doesn't resonate with our community. And you can tell that perhaps, whoever is coming up with these things isn't exactly from that community or doesn't have a relationship with that community. So even if your goal is to try to reach folks, then you really have to include them in the process in a meaningful way and early on.
Oh, so I think that's important to understand that not everybody's comfortable with these new changes in the mandates. People are starting to lose trust in some of the recommendations because they don't have a connection with the people giving the advice. And I think that's true not only at the national level, but at the state and local level, and even into lots of doctors' offices. Many times, people, especially of low income, they come in to see different doctors all the time. And now here comes a doctor to tell you to get you get a couple of shots, then you need a booster, then maybe you need to do something else. I think that becomes a problem, and systems are going to have to change if we aren't going to face the same thing with the next pandemic. So
If I could add one thing in terms of for the population, and we've gotten into a rhythm, right? We have expectations when we engage in healthcare. Healthcare, you go there with a problem, you get a solution, you go home. And so what's happening is with COVID is we're seeing science and healthcare play out in real time. And so as these problems are coming up, they're happening in real time. Solutions are happening in real time, and sometimes the solutions are effective and sometimes they're not. And so the solutions keep changing because the problems keep changing. When you have a new variant and how that variant attacks the body, that's a new problem. It has to have a new solution. And then as the numbers go up and down, mandates go up and down. And so I think people have to be a little bit more patient, allow healthcare officials a little bit more grace when it comes to the situation, because again, science is playing out in real time, and that's normally not how it works.
That's a very good point. Why don't we go and see what Dr. Donna thinks we need to know this week?
This is what you need to know this week. Number one, you need to know about the vaccines for the 6-month-olds to 4-year-olds. Now, you probably heard in the news that they were coming soon, and February 15th was supposed to be the day that it was going to be voted on by the FDA. Well, the drug company decided that they wanted to postpone it and delay that vote. And the reason is because they had studied a 2-dose regimen of the vaccine. And in those studies, they realized, well, maybe 2 doses isn't really enough. Maybe we should start out with 3 doses. Your second need to know is about COVID variants. Are there still variants? Yes, unfortunately, we are still going to see variants, and we're going to continue to see variants for as long as we have a high percentage of people who have not either been vaccinated or their immune system from their first vaccinations is so low that they're not really as protected. And so we're still going to see variants. The third thing that we need to know, we're going to talk about masking. And I know that in many, many areas of the country, here where I am in Alameda County, the mask mandate is being dropped. Going indoors, you no longer have to wear a mask. Well, I'm hoping that what I just told you about the possibilities of disability after getting the virus, that will make you think twice about removing your mask when you're indoors. I personally am going to continue to wear my mask. Indoors, outdoors, whenever I'm in crowded places, I'm going to continue to wear my mask. Again, I did an episode on what type of mask to wear and how to wear a mask that fits well. So look on my channel and look at that masking video. A K95 or an N95 is the best type of mask to help protect you from getting coronavirus. And even if somebody that's with you or you're in a place where they're not wearing a mask, you wearing the right type of mask could protect you and help prevent you from getting this disease. So those are Dr. Donna's need to know for this week.
All good points. And one of the couple of issues we need that I'm concerned about this week. Well, first of all, I don't know which organ system to protect. Am I going to protect my heart at the expense of my diabetes? Am I going to protect my lung at the expense of my kidney? And I just saw an article this morning, so people know we're right on top of the news, that said that drinking glasses of wine in the evening helps you to control your diabetes. last week, it was any wine affects your heart. So I don't know how to make that. I'm sure you must hear more of this than I hear.
It's funny that the marriage of what Dr. Donna was talking about and an article that I was bringing today is saying that COVID has caused a number of people to develop diabetes as a result of it. But the new study is showing that those people that were hospitalized with COVID and developed diabetes as a result, about half of them returned back to their pre-COVID levels, their pre-hospitalization levels, which means they don't have to, and only about 8% after a year were still on insulin. And so seemingly that it could be a stress inflammatory response by having COVID that is causing them to be diabetic. But the good news is that most of those patients are returning to their pre-COVID numbers.
Yeah, so but it's still a little confusing. I think there's there are always some hit things. Coffee, they're always after coffee. They're definitely always after any kind of drinking. But this latest article suggested that drinking a little wine every evening makes us helps us to control diabetes. So we have to kind of keep our eye on that because it's going to change next week.
So drink your wine while it's still hot. While that story is still new, drink your wine, Doc, until they change the rules. Go ahead and drink your glass.
You'll have to give me more evidence than that, man. But let me say this. But diabetes is a very serious problem for us.
Yes.
You look at the statistics that came out recently. African Americans are twice as likely to get diabetes and to keep it uncontrolled. One of the reasons I think many times for people not to be able to control their diabetes is that the medicines have been so funky, and that's not a medical term, but right. The medicines have been hard to regulate, a lot of hypoglycemic episodes. And so I had a conversation with Dr. Leonore Coleman about the new medications and how that might be easier for African Americans to control diabetes without as many side effects.
Classes of drugs that have come out in the last 5 to 10 years are your DPP-4 inhibitors. Those are oral pills. All right, those drugs actually work in the area of the gut, and there are basically hormones in the gut that can make your blood sugar go up. So these drugs decrease the ability of those hormones to do that. The other class that falls in there is the GLP-1. That's an injection. I happen to like those drugs the best. The reason why I like them is that they decrease your hunger. They are so effective in helping you to lose weight. And most people with high blood sugars are overweight. So I really like the GLP-1 inhibitors. You've heard them on the TV. Trulicity. Maybe you've heard that one it's once a week. Victoza has been out there for a long time. There's a number of those drugs, Rexultis, semaglutide, you've heard Ozempic. Those commercials, all of those are in that class of GLP-1.
Yeah, one of the yes. How often is hypoglycemia when you use those drugs?
This is what's so wonderful about those new drugs, the DPP-4s, the GLP-1s, and then the other class of drugs that you know about, Mike, are the SGLT2 inhibitors. They work at the kidney. Those are also new drugs. And they actually have done some studies where they show that they help to prevent kidney disease, and they help with people who have heart failure. Mm-hmm. So this is good. They've done some extra studies on those drugs. So at this stage of the game, in 2022, can I please tell your audience that nobody should be using sulfonylureas? And let me tell you why. Sulfonylureas, that's your glipizide, your glyburide, your glimepiride. Those drugs lower blood sugar whether it's high or not. So they cause hypoglycemia. That's what you just talked about, low blood sugars. But the newer drugs only work when the blood sugar is high. So they do not cause your blood sugar to fall like the sulfonylureas. So it's really important because hypoglycemia, low blood sugar, is more dangerous than high blood sugar.
Yeah, well, I'm glad that, that people, because, there are a lot of people they're on metformin than any other drug.
Yeah.
You're saying that that's not may not be the way to roll.
Well, it's not enough. Everybody usually starts off with metformin, all right? But I'm a proponent of starting people off with 2 medicines right off the bat, right? So a lot of times we wait too long trying diet and exercise and one drug when we know that it takes 2 to 3 drugs to control one's blood sugar.
Right. Well, so it's a lot of good information from her. These new drugs, I think, are really good. When I was diagnosed with prediabetes, I tried taking metformin, but sometime in the evenings I'd be jittery and sweating, and it just didn't seem to be a good drug. What she's saying is that these new drugs are less likely to cause a drop in your blood sugar to the point where you're symptomatic. The problem is getting access to them. They're very difficult for.
And that's been the biggest challenge. And Dr. Coleman does a great job of making sure she gets that information out, specifically for Black Americans, because some of those new drugs, as she mentioned, as she alluded to, will help you control your weight. They help you suppress your appetite, and they'll also, so you'll lose weight as a result of taking those drugs. There's some other things you can do as well. There's an article out on blackdoctors.org now, talking about chia seeds, right? So you can add chia seeds to your diet. They have a lot of protein, and they also help regulate your blood sugar. So if there are some things that you can do outside of the medication, sprinkling some chia seeds on your salad or in some of your food can really help lower, particularly if you're hypertensive as well, can help regulate your blood sugar levels and give you some protein for energy and help you process other nutrients in your body. So sprinkle some chia seeds and you'll be, and that can help as well.
Here's my problem. Where do you get chia seeds? I have all of these stuff that you're supposed to use for diabetes, heart disease. Where would I go to get me some chia seeds?
Chia seeds are commonly in your grocery store. You should be able to find them in your local grocery store on the aisle where they have the spices, right?
I've never seen no chia
spices
seeds.
And baking. Spices and baking. Agnes, would you please tell Dr. Lenore where he can find some chia seeds? Thank you, Agnes.
The grocery store. You must be going to some up-level grocery stores, because the grocery stores I go to, I've never seen any chia seeds.
Agnes said Costco and BJ's. So
all right. Well, Costco, you got to get 5 years worth of chia seeds. Well, one final thing I think we should just at least mention from the National Center of Health Statistics, that African-American individuals have a disproportionate cancer burden, including the highest mortality and the lowest survival rates. Black men have 6% higher incidence rate, overall cancer mortality, disparities narrowing between Black and white men because of a steeper drop in Black men for lung and prostate cancer. But Black women have an 8% lower incidence rate than white women, but a 12% higher mortality. Further, mortality rates are twice as higher for endometrial cancer and 41% higher for breast cancer. Now, a lot of that has to do with how the system treats us, but a lot of it has to do with how we treat ourselves. By that, I mean that we need to start making sure that we get these screens that are designed to pick up these problems with cancer early in the game. Mammograms and prostate exams, be they laboratory or physical, I think are probably the two that are most likely to reduce a lot of these statistics. But I'm really concerned about endometrial cancer rates and also breast cancer rates in women, because a lot of those are as preventable as prostate cancer is for men. So we're still, while we're doing better in terms of morbidity and mortality, I think this is a very telling statistic that we are more likely to have the highest mortality rates and the lowest survival rates of any racial and ethnic group. And I think
there's a couple of things. There's some great information that we had earlier this week. We talked to Dr. Monique Gary. She is a breast cancer surgeon in the Philadelphia area. And matter of fact, yesterday was triple negative breast cancer day. So, and one of the things when we discussed it is that in terms of Black women, triple negative breast cancer is most common. It's one of the the hardest to treat in terms of cancers, and it attacks your body earlier, so you get diagnosed earlier. So particularly when it comes to Black women, there is a tendency to have a denser breast tissue, and so when you're doing your mammogram, sometimes they can't get a reading to find the lumps. So if you do, when you get your report back, there's some information on that report that can say, hey, that will basically let you know that your breast tissue is a little bit thicker and they can't get a good reading. So at that point, you should request an ultrasound and or an MRI to get more information with regards to if your mammogram is inconclusive. So don't stop at the mammogram. Don't stop, as they say, don't stop, get it. Get the ultrasound and get an MRI if your mammogram is inconclusive.
I really appreciate your contribution to these discussions, because that really focuses what we're trying to do with our news program, is to keep it real and give people a call to action. And certainly for breast cancer and for prostate cancer, you have to be in control, not only of the management once you've made the diagnosis, but the diagnosis. You got to make sure you get the stuff that you're supposed to get. For instance, in the area of prostate cancer, instead of about 500,000 biopsies, you can get an MRI now.
Yes, you
and
can.
So there's certain things that you need to know before you go even into the management phase about the diagnostic phase. I said the final, and this is the final discussion.
Final.
One of the disturbing studies that I just saw from some of the literature was about the impact of COVID on pregnancy. Now, we already know that we have a terrible problem with Black prenatal mortality rates.
Yes.
And it turns out that during the COVID epidemic, the Black maternal mortality rate was 2.9 times higher, 14% higher than even in the previous studies. So there is, we're just really starting to understand and appreciate the impact that a COVID infection has on pregnancy. I think 14% higher than the previous year, 2.9% more deaths among African-American women than other women. So I think we need to still kind of keep an eye on this virus to see exactly what the long-term implications have been and will be from the studies that we're getting.
Absolutely. And you got to think about, you also have to think about COVID being more of a vascular illness than a respiratory. I know people always talk about when they got COVID, they can't breathe, but some studies have shown that it attacks the vascular system, the overall vascular system. And that's why it's impacting your hypertension, it's impacting the kidneys, it's impacting your erectile functioning. And you think about vascular, if a mother is pregnant, they need that system, that connection to the baby, to be clear and free from all type of blockage. And so if you've got the situation where you got a mother that's pregnant and she contracts COVID, that could impact the sharing of fluid and food and nutrients to the child, and could kick in that maternal mortality rate outside of what's already happening to Black women. So we've got to do, Agnes, so Doc, we've been invited to New York.
Yeah,
they want us to come and do a pop-up show there in New York.
All right, I'm ready. I'm ready to come back to the Big Apple.
Agnes, when they drop the mandates, I'm coming.
Yeah, but look, when they drop them for Kyrie, then I know it's time for me to come. But I wanted just to say that when we look at, I'm trying to remember exactly what I wanted to say about this. I forgot, but anyway, it's time to roll on out anyway. So thank you very much for joining us today on the Dean and Doc show. I think you will find that every week we'll bring you some of the latest information about aspects in health. We're trying to keep it real, and we're trying to give you a call to action. And if you would email us at aawellnessproject.org, we're giving away a book. The book is called Focus on Your Best Health.
Yes.
And it's a book that talks about navigation and advocacy in the healthcare system. And always remember, as my signature, sign off like any one of the superheroes, health is your biggest asset, so protect it.